I'm very happy to be able to give this webinar. If you have any questions, please interrupt. For the moment, I cannot see you. So I'm going to talk about ABO incompatible renal transplantation in children. Just to give you a background, a brief background about myself, I started to work at the Department of Transplantation Surgery in 2002 at the Karolinska University Hospital in Stockholm. I defended a thesis, ABO incompatible kidney transplantation, in 2008. I have written some publications on ABO incompatible kidney transplantation, and I am currently the supervisor of a PhD student, Felicia Kärnet, who is also going to present our results from the Nordic countries about ABO incompatible transplantation. I have nothing to disclose. So I have basically 3 key points of this presentation. First of all, ABO incompatibility used to be and still is in many places the most common cause of refusing a potential living donor candidate. And in spite of successful programs for ABO incompatible kidney transplantation in adults, ABO incompatible kidney transplantation in children is still a rare event. In spite of very good results, in the Nordic countries, our experience is actually that graft survival in ABO incompatible children is superior to graft survival in deceased donor kidney transplantation with compatible donors, and similar to living donor kidney transplantation with ABO compatible donors. I will give you a brief presentation of previous experience. I'm going to talk about some caveats. We will discuss our 2 ongoing studies on long-term outcome and complications in pediatric ABOI kidney transplantation and the rituximab in pediatric kidney transplantation, some future projects, and then I will try to answer your questions. The first, at least published case on ABO incompatible kidney transplantation was performed already in 1952, and it didn't go so well. Here you can see a necrotic glomerulus, and the reason for why they did this transplantation was simply because they didn't know that the ABO barrier would be a problem in kidney transplantation. However, that quickly became clear, so over the next 30 years, virtually no ABO incompatible kidney transplantations were performed, only a few accidental ABO incompatible transplantations. And in an analysis of these accidental transplantations, a 1-year graft survival was only 4%. We nowadays know that the A and B antigens are expressed on virtually all cell types of the body. So the antigens can be found in the glomeruli, in the tubuli, and in the blood vessels of a kidney. Here it stains brown. It's the A antigen from one of our donors. So why did we start this program? Well, first of all, as I mentioned, ABO incompatibility used to be the most common contraindication to donation. So we wanted to expand the donor pool. But in the 90s, there was also quite a remarkable difference in both patient and graft survival, depending on donor source. So another incentive was actually to increase the proportion of living donor kidney transplantations. Our program for ABO incompatible transplantation started in 2001. The pediatric program in 2003, and quite early we were happy with the results, and we were able to transplant also small children in the need of an ABO incompatible kidney. We could see that the protocol worked just as well for children as for the adults. It effectively eliminates the blood group antibodies, and there was virtually no rebound. However, our experience and also the experience in Japan and elsewhere is that very few ABO incompatible kidney transplantations are performed. In the red box, you see the proportion of pediatric ABO incompatible kidney transplantations in Japan, only 4%, in spite of very good results. We also have a similar experience. Over a 15-year period, we have performed in Scandinavia 34 ABO incompatible transplantations. So can we learn things from other areas of ABO incompatibility, and what are those? Well, first of all, pregnancy, blood transfusions, especially platelet transfusion. Commonly, platelet transfusion is performed across the blood group barrier. Many hematopoietic stem cell transplantations are also ABO incompatible, and there are a few reports on deceased donor liver and heart transplantation. We and others the results from our own results and the results from other centers is that in adults, ABO incompatible kidney transplantation is just as good an alternative as ABO compatible living donor kidney transplantation. Here you see patient and graft survival from the largest analysis of ABO incompatible transplantation. No difference when compared with compatible controls. And similar results are reported in heart transplantation, although they are not able to precondition their recipients. They also find in pediatric heart transplantation graft survival, which is similar to ABO compatible heart transplantation. So are these antibodies actually harmful? Well, I would say it depends on the level of antibodies. In blood transfusions, there have been an analysis performed on 15 ABO incompatible cases, the titer ranging from 16 to over 8,000, and in this report, there were 2 fatalities. In platelet transfusion, the ABO incompatibility can be either major or minor. I would say minor, which is the passive transfer of blood group antibodies together with the platelets, may cause severe hemolysis and even death. So one challenge in ABO incompatibility at present is that no one can tell what the critically high level of blood group antibodies is. There is no consensus. It is known from hematopoietic stem cell transplantation that a titer above 64 may lead to prolonged red cell aplasia. But there are also reports, again, from the heart recipients that the immune system of the recipients undergo several steps of adaptation following an ABO incompatible transplantation. And what influences the level of the blood group antibodies? First of all, females usually have a higher level than males. Young age, at above 8 years of age, when you normally reach adulthood level of blood group antibodies, have higher levels than older people. The blood group antibodies are also highest in blood group O individuals, and it may increase after an ABO incompatible pregnancy, and it can increase after an ABO incompatible transfusion. Processed food induces a lower, does not lead to an increased expression of blood group antibodies compared with not processed food. It has been suggested that vaccinations, at least before, could induce blood group antibodies, and that probiotics may induce blood group antibodies. My suggestion is therefore that if you have a child scheduled for an ABO incompatible kidney transplantation, don't give the child probiotics beforehand. IVIG is actually also transfer of blood group antibodies, and I will come back to that. The blood group antibodies may alter over time, the same as with other antibodies. You first have a fairly slow immune response with a fairly low level of antibody expression. If you then have a second immunizing event, the antibody response is much faster and the antibody titer may go up a lot. There is a case report of a blood donor who had a low titer of around 16 and then started to use probiotics, and the blood group antibody titers went up to 32,000. When it comes to vaccines, there is a study on soldiers undergoing multiple vaccinations. And in this study, using modern vaccines, there were actually no sign of immunization to blood group antibodies. So when it comes to vaccines, I would say they are safe. Next question is how to determine the blood group antibodies. The classic way of measuring the antibodies is through titration using an agglutination technique. This is not standardized and the reproducibility is not very good. Another method, which is a bit more sophisticated, is to use the gel tubes. Here, if you use the same test erythrocytes, the method becomes reproducible. However, the test erythrocytes are not standardized at present. So therefore, you can still get a result that varies a lot. We compared ourselves the gel tube technique, and we could see a difference in 5 titer steps depending on the center doing the analysis. Gold standard to measure the blood group antibodies is through flow cytometry. However, this technique is not very suitable for acute analysis. So, there is no standardized technique to measure the blood group antibodies today. Now the protocol. I will start talking about the original Karolinska protocol. It contains 1 dose of rituximab, the B-cell depleting agent, which is given a month before transplantation. In the beginning, the patient started the oral immunosuppression 10 days before the scheduled transplantation, and then they were all scheduled for 4 immunoadsorptions before transplantation to reach an antibody titer below 4. They were also preventively scheduled for 3 post-operative immunoadsorptions. And right before the transplantation, the patient was given 1 dose of IVIG. However, it turned out that IVIG contains a fair amount of blood group antibodies. A titer of 64 is the maximal allowable titer in the IVIG preparations available today. And this varies quite a bit between different preparations. And here you can see the post-operative apheresis. Nowadays, we have adapted the protocol. First of all, we basically follow the algorithm developed in Heidelberg. So if the patients have a high titer preoperatively, they're scheduled for more immune adsorptions than if they have a low titer. So nowadays the protocol looks like this. They still get a single dose rituximab. We have omitted tacrolimus before transplantation. We had an increased rate of delayed graft function when starting tacrolimus beforehand. They are scheduled to get a varying number of immune adsorptions beforehand and no post-operative immune adsorption. And how does it go? Well, as I mentioned, there are a few publications on pediatric ABO incompatible transplantation. Here is a study from London, including 2 centers, 11 patients. They didn't see any difference in eGFR, rejection-free survival, CMV, EBV, and BK viremia when compared with ABO compatible controls. There is also a study from Japan with similar results. And a second study from Japan, which is actually the largest study on ABO incompatible kidney transplantation in children, including a summary of complications following ABO incompatible transplantation. The study is done through a survey to all centers having performed ABO incompatible transplantations, and it shows really excellent results. They also have summarized complications, and I would say the complications are fairly infrequent. Our own experience is somewhat different. Now I'm going to pass the word over to Felicia Kärnet, who will present our results from the Nordic countries.
Hello, everybody. Can you hear me? Oh, I don't hear anything.
So yes, perfect.
Yes, great. Yes, my name is Felicia Kärnet. I'm a surgical resident and also Helena's PhD student. I'm going to present a multi-center investigation from the Nordic Pediatric Renal Transplantation Study Group on outcome and complications in pediatric ABO incompatible living donor kidney transplantation. Pediatric ABO living donor kidney transplantation been performed within the Nordic countries since 2003. During the study period, 6 out of the 11 centers within the NPR-TSG performed pediatric ABO incompatible living donor kidney transplantation. And to compare results, all pediatric kidney transplantations performed at these centers were included in the study. It was over 400 transplantations in total. Relevant data been retrieved from local registries, patients' medical records. Exclusion criteria for the study were multi-organ transplantation and total loss of follow-up after first hospital stay. For patients receiving a transplantation and later retransplanted within the study period, only the first transplantation is included. A total of 391 pediatric recipients were included in the analysis, was 34 incompatible living donor kidney transplantations, 258 compatible living donor, and 99 compatible deceased donors. Just a short presentation of the ABO incompatible living donor kidney transplant group. No one were preoperatively splenectomized. All except for 2 received preoperative rituximab, and almost 80% retrieved preoperative apheresis, and approximately 1/3 received the postoperative apheresis, and 50% of those were per protocol. 41% received preoperative IVIG, and the median titer at baseline was 32 and a transplantation 2. A significant difference in recipient age between the study group was observed with older recipients in the incompatible living donor group compared to the other two groups. Complication first year after transplantation were defined as an unscheduled readmission to the hospital. During the first year, approximately 61% of the patients had one or more unscheduled readmission, and approximately 40% were readmitted more than once. No significant difference were observed between the groups. 18% were readmitted due to rising creatinine without known cause, and 8% were admitted because of diarrhea, vomiting, with no significant difference between the groups. During the first year, unscheduled readmissions due to infections occurred in 41 or 36% of the patients, with no difference between the groups. No patients in the incompatible group suffered from delayed graft function, and no one died within the first year. Graft function using measured GFR did not significantly differ in any of the group at follow-up the first 5 years. No incidence of PTLD or other malignancy during follow-up were observed within the incompatible group. Patient survival at 10 years was 100% in the incompatible group, 97% in the compatible living donor group, and 93.5% in the deceased donor group. And graft survival was higher in the incompatible group compared with the other two groups, as illustrated in this Cox regression curve. So for the conclusions, so far, we did not observe any significant increase in mortality, graft failure, or complications in the incompatible group. In fact, graft survival was higher in the incompatible group, and the incidence of malignancy was 0. So the preliminary results of this study suggest that pediatric ABO incompatible living donor kidney transplantation is comparable to ABO compatible living donor kidney transplant and superior to deceased donor kidney waitlisting. And ABO incompatible should not therefore impede living donation. Thank you. I will give the headset back to Helena.
Thank you, Felicia. I'm now going to talk a bit about rituximab in pediatric kidney transplantation. Rituximab is given to all our kidney recipients undergoing ABO incompatible kidney transplantation. And the reason is to prevent antibody-mediated rejection. There are centers doing adult ABO incompatible kidney transplantation nowadays, excluding rituximab from their protocols. However, we believe that it is beneficial long term, and in this study from Japan, they could see a much lower incidence of de novo DSA in ABO incompatible kidney recipients compared with those undergoing ABO compatible transplantation. We know from a previous study that the effect of rituximab is profound and long-term. Within the green box is the B cell count in adults, I should say, before administration of rituximab, then at 1 month, and then also long-term, you can see that the B cells are clearly reduced for a very long time period. We have conducted a sub-study on single-dose rituximab induction and EBV viremia in the cohort just presented to you. Again, data from the NPRTSG group within Scandia Transplant. The background was that 2 placebo-controlled trials in adults evaluated rituximab as a prophylactic anti-rejection therapy. One was done in Stockholm and the other one in the Netherlands, but none of these trials could prove any clear benefit of rituximab within 180 days of follow-up. No such prospective randomized trial has been performed in children in fact, very little has been reported on rituximab induction in pediatric organ transplantation. So the aim of this sub-study was to evaluate the long-term effects of rituximab in pediatric kidney transplantation. Again, similar cohort of patients, but we only included first-time kidney recipients and those with EBV serology available both from the recipient and the donor. So the complete data set contained 240 pediatric kidney recipients. 27 of those received single-dose rituximab induction and 213 did not receive rituximab induction. So follow-up was 9 years. Patient survival in the rituximab group was 100% and slightly lower in the non-rituximab group. Graft survival was nearly 93% in the rituximab group compared with 84.6% in the no-rit group. In the rituximab group, nearly 31% of patients were treated for acute rejection compared with 15.6% in the group among the patients not receiving rituximab. There was no significant difference in EBV serology between these two groups. EBV mismatch, however, was associated with an increased risk of EBV viremia. 7 patients in the no-RIT group were diagnosed with malignancy compared with 0 patients in the rituximab group. And here you can see a graph illustrating the cumulative hazard of EBV viremia following rituximab induction or no rituximab induction. None of the patients in the rituximab group was diagnosed with EBV viremia during the first 3 years, compared with 34% in the group of patients not receiving rituximab induction. The incidence of CMV and BK viremia did not differ significantly between the two groups. And regarding EBV-associated PTLD, similar results are reported elsewhere. In this Japanese study, now viral infections is highlighted instead of EBV-associated PTLD, 2 lines down. There were 2 cases of PTLD among the ABO incompatible patients. However, in this Japanese study, they did not have a single case of PTLD, but there are 2 cases reported in living donor liver transplantation. Excuse me. So in conclusion, single-dose rituximab induction in pediatric kidney transplantation appears safe. Rituximab may have limited potential as inhibitor of early acute rejection. Single-dose rituximab induction in pediatric kidney transplantation seems to effectively prevent EBV viremia long-term. Data herein indicate that rituximab induction could be a forceful strategy to reduce the risk of PTLD, but further trials are needed. So, I'm so sorry about the summary here being like virtually blank. It's because we don't have the latest version of the presentation. But we have gone through our conclusions, and planned studies for the future is to perform deceased donor ABO incompatible kidney transplantation. And one may ask why this should be done. My answer would be that it could increase accessibility to transplantation, especially for patients that are hard to match on the waiting list, and it could also increase the total number of transplantation. And is it possible to do deceased donor ABO incompatible kidney transplantation? Well, I would say yes. There is a case series from Australia not giving any preconditioning before ABO incompatible transplantation at all to living donor kidney recipients with very low titers. This means that this protocol could be applicable even in the deceased donor setting. 3-year graft survival in this study was actually 100%. We also want to evaluate rituximab as a way to reduce the risk of PTLD, especially in patients that with a donor positive kidney that are EBV negative themselves. So in conclusion, overall, patient survival following ABO incompatible kidney transplantation is similar to standard ABO compatible living donor kidney transplantation long term, and possibly superior to deceased donor waitlisting. Graft survival is also similar. I would say argue that it is actually superior to deceased donor kidney transplantation. Single dose rituximab induction in pediatric kidney transplantation seems to effectively prevent EBV viremia long term. I'm very sorry, but about this this version of the presentation. Anyhow, ABO incompatible living donor programs may reduce the waiting time for blood group O patients in the need of a deceased donor organ. I didn't mention this, but when we assessed the number of patients on our waiting list, we could see that after the introduction of the ABOY program, there was a decline of patients in blood group O on the waiting list. Thank you. I want to acknowledge our co-authors in these 2 studies we've gone through and the people that have helped us, especially Anne-Karin Asperheim, our living donor coordinator, and Ilse Dus Weinreich at Scandia Transplant, and Mikkel Mögelvang in Copenhagen. I also would like to thank the people sponsoring the study.